Good evening and welcome to the NDTV Dialogues, a conversation of ideas. This week, for our big idea, we have a distinguished panel to look at what is being pitched as the world's largest government-funded health insurance scheme, Ayushman Bharat, or Modicare, as it's often popularly called. But now, perhaps, to get all states on board, it's going to be called Ayushman Bharat. Is this a game changer for India? Health finally on the mainstream agenda. Joining me for more is the man who's in charge, the man in the hot seat, Indu Bhushan, the CEO of the scheme, who came back after 21 career with the Asian Development Bank, convinced by this. Also with me, Dr. V.K. Paul of NITI Aayog. Dr. Paul, of course, had a long, distinguished career in healthcare, including in the All India Institute of Medical Sciences. I'm also joined by Sujata Rao, again, somebody with a career in healthcare. She was the ex-Health Secretary of India. Also with me is Shamika Ravi of Brookings India. She is also currently on the PM's Economic Advisory Council. I'll also be joined by Preetha Reddy of Apollo. Thank you all very much for being on this panel. Dr. Indu Bhushan, thank you for being here, because I know you're traveling from state to state, really to meet chief ministers and see how the program is doing on the ground after the launch just about a month, less than a month ago. How do you think it's going so far, and what would you explain the big picture of this scheme for the people who are watching?
So far, so good. We've had more than 80,000 e-cards made. We have more than about 40,000 people who've been provided treatment, and claims worth more than 50 crores being raised. So we are seeing a good uptake. Some states need to do more, and I don't blame them, because they are doing a scheme of this kind for the first time. So. But in next month or so, we'll be firing on all four cylinders.
What do you think, if you had to describe the scheme today, what would you describe as the main points, and what the main issues of it actually are? What is the main point, the vision of this scheme? Well,
main vision of the scheme is that large number of people, by some estimates about 6 crore people, fall into poverty because of expenditure on health, and that's unacceptable, and this scheme is going to prevent that. Second is that access to quality services by poor people at the bottom of the ladder, is limited, and this scheme is going to change that. Availability of services in tier 2, tier 3 cities, rural areas is limited. This scheme is going to change that.
Dr. Paul, if you could come in as well, because of course with your experience at All India Institute of Medical Sciences, we saw people from around the country coming to AIIMS mainly because they didn't have access to quality health where they were, or where they went to private hospitals, then they just couldn't afford it anymore. What do you think would be the major change? We call this scheme a game changer. What do you think this will be the major changes brought about by this scheme?
I think first and foremost, making access possible for the bottom 2 quintiles, the 40% population, toward secondary and tertiary care hospitalization. This scheme is not about outpatient care. There we are building the health and wellness centers, and that's the other component of Ayushman Bharat. But hospitalization is a big issue. 32% of the out-of-pocket, 32 to 39%, another estimate, is due to hospitalizations. But more important than that is the point that this population never had access beyond, let's say, maternal and child health care services, which we created and connected poor people to during the phase of National Health Mission. This access was not there. So it's above all about poor people. And actually it is, as you know, from 40%, it's not just BPL. We are already higher than BPL. BPL is about 18-20%. 40% of the bottom of the pyramid population now will have access by right to care, both. In the second part of this game-changing scheme is through empaneled private sector hospitals as well as government sector hospitals. So this is the key, and it opens up a possibility of a rickshaw puller having, a stent being put into him if need be, or a farmer's wife getting full treatment for carcinoma breast, let's say, which is never possible with a coverage of as high as 5 lakh per family per annum. Such possibilities have opened up. So to me, I would say access to one system in India, which is a combination of public and the private sector, to me is the highlight of this.
And I think the big idea really no one will argue with, because really the concept of universal healthcare, Sujata Rao, has been something that has been discussed in India for years now, but somehow the political will and the financial backing, because both really must go together. The fact of how much of our GDP we actually spend on health, how we'll finance a scheme like this, those are two issues that must go hand in hand. One, first, the fact that now finally it's part of a political mainstream agenda. It's been backed by the Prime Minister from Red Fort, and the fact, where are we getting the funds for it? Because the funding has been questioned. Also, are we looking at, maybe farming it out, it's private, public? We know that private healthcare is already 80% of India, much higher than it is in most other countries. How are we looking at aspects like this?
Well, to your first question, whether, in India, when it got its independence, there was this whole concept of Bhore Committee, which said none should be denied healthcare for want of ability to pay. So that's how we started our journey. But then we were beset with so many developmental issues as a post-colonial country and all that, we could never really get to reach that aspiration. And then UHC has been popping up. It was 1991 that civil society put this on the agenda, saying that we must have UHC. But it got traction only in 2009 when Rockefeller Institute really made it a global agenda. And now it's got further traction with SDGs in 2015, which made this a particular goal for all countries to achieve. So India didn't lack the aspirational goal, it didn't lack the necessary ideas, but India has never been able to achieve it largely on two grounds. One was that there's never any money. I mean, our development model was such that both health and education kept getting lower priority to manufacturing or, the economic sectors, as they call it. So there was never enough money, and that's the reason you will find that over the last 70 years, we've never spent more than 1 to 1.23% of GDP on health, public spending, which is so low, which is one of the, India is one of the 15 countries in the world that spends as low as this in terms of public investment. So with this low investment, we were never able to build up the infrastructure required, and so private sector really came in, and since we were not able to ensure what Indu said, the out-of-pocket expenditures in seeking care really went up so high that we do have about 5% of our population getting below poverty line. Now, the moot point is, therefore, I mean, anything done in health, I have seen health for so long that for me it's great news. So I'm very, very glad that this step has been taken. I don't know whether it's a game changer or not. That time will tell us, but it's certainly a big step taken forward. And I want to just explain two things. One is that this hospitalization based health insurance the journey started in 2003 with Yashaswini, and then it was Shamika Ravi government in 2007 which set up the Rajiv Arogya, which entitled 85% of the United Andhra population to a similar entitlement. So Tamil Nadu, Kerala, all of South, Maharashtra, West Bengal, they all have a health insurance program, similar hospitalization, and for a sum assured, cashless, and so on. It is then the RSBY came along in 2009, but then UP and Bihar left it after a year or two. Now, why did that happen? So there are three challenges. One is, even if we implement this in full steam, even then we will only be addressing 20% of the out-of-pocket expenditures. The major 3/4 of expenditures is on outpatient treatment. So that has to be arrested. And secondly, what Dr. Paul was saying, the wellness clinics assume a huge importance, and I mean wellness not only the sub-center, but I take it as euphemism for primary health care, because there is no way a hospitalization, this strategy can succeed without being based on the foundation of primary health care. That is so fundamental, and there's adequate evidence to show that a strong primary health care can avert at least 30 to 40% of hospitalization, which is a big saving if you really take the unit cost of a hospital care. Only the second point I'd like to say is the second constraint is not going to be so much money. You asked me about the money part. Money will be a problem because health expenditures are going to be very, very closely linked with the overall economy. And if what today's newspaper said, if the economy is having a problem, the ability for it to fork out this kind of money for this scheme will be a problem. So I see, just very quickly, and I'd like to flag this, my worry is that when money is not adequately provided for and is not available in the system as a whole, you brought this high cost, it is a high cost scheme, well intentioned, but it might, and I fear that it might divert the money from my infectious disease control programs and other programs, if the health budget doesn't expand the way it should,
no, that's an
then
interesting,
it might end up
that's an interesting
diverting
point.
money,
Why
and that
treat
is
a
worrying.
patient when he's at dialysis stage? Why not catch it at the primary stage? I just want to bring in first Preetha Reddy, who also joins us from Chennai, because we've been looking really, Preetha Reddy, at the whole private sector involvement. We've known that often the private sector, in fact, is the major healthcare provider in India today. It has been out of access for many people of India who couldn't afford it. This means to actually completely transform that. How do you think this is actually going to work? We're discussing whether this will really be a game changer in India's health provisions, in India's healthcare.
Good afternoon. This is Preetha here, and it's great to be on this panel with all friends who we know and who we've been working with. We cannot go away from the fact that the private sector is 80% of India's healthcare provider, and that space will stay, it will remain, and there is so much we can do together is definitely a fact. I think we're coming to terms with the fact that I personally think, and I think the industry also thinks, that this whole Ayushman Bharat is definitely a game changer. There's no going away for it. I've been talking, I was in the US lately talking to economists from Stanford, and they think that, whatever has been done is, we need the courage, we need the daring to do it. And I think the government has done it, and we have to applaud that effort. How many people and how deep will the penetration be? This is not something which is going to happen in 12 months or 24 months. It is a change which is going to happen for the rest of the country. It may be over a period of 5 years, 10 years, 20 years. It's going to outlive our times. But I think that the fact that an ecosystem has now been put into place is phenomenal, and there's absolutely no going away for it. Can the private sector really work with the government on, especially to start with, on providing the tertiary care requirement? I think that's a possibility. We are a bit concerned and in dialogues about the cost of care, which I think, we have to raise some red flags from the private sector, which is being done, and it's being, thought through, understood and contemplated. So I'm sure that will evolve as a system. But primary care, I think, is, is something for a population of this size, a large focus on primary care becomes absolutely important. Right. And I think we have to work our way through that, and I'm sure we will do it. The other question which always comes into mind is, how do we finance this? Where is the money? Where does the government have the budget? There's money in the system. We might have to be more innovative and take the southern states, for example. They have insured people. There is a scheme. It's reaching out to people. Right. It's growing at 25-30% year on year. So there are funds available to really make it go. Maybe we should do a co-pay system. We need to think about that.
Of course, and it is of course also 60%, 40% right now. Let me just bring in Shamika Ravi, because Shamika, so many different aspects. I'll try to narrow it in our next round. But just looking at the different concerns and red flag areas, and also, of course, the big positives emerging from our discussion so far.
Well, I'm all for it, largely because I think health has to become a political agenda in this country. It has been long neglected, and that goes for both aspects of human capital, health and education. This is an enormous step in terms of mainstreaming healthcare concerns as a part of economic or reforms broadly. Tertiary care is one part of it. Of course, it's a large contributor to the out-of-pocket. So what you've heard all the panelists say, absolutely correct. 7% is getting impoverished. So this is a great move towards assuaging or giving that extra support to handling of the health burden that households have to live with. But the one part of Ayushman Bharat which I think the media does not pick up, Sonia, and I do have a concern with that, is the wellness part of it. Wellness center is as much a component of Ayushman Bharat as the health protection scheme. In fact, all the research that we have sort of done based on Indian household data, we know that this is a gatekeeping that happens. If you have stronger primary care, then the reliance on tertiary will obviously fall. And so it's effective even in the long run to have those mechanisms. And we need to actually support and raise questions and issues also for the primary care centers. which are now going to be wellness centers. But you know, spending is very small part of this problem of healthcare. India, if suppose you double the health budget of Uttar Pradesh or Bihar tomorrow, you really think we will solve the problem? It's very much a governance issue, in which case I think right now writing a check from Finance Ministry to health perhaps would be the easiest thing to do. What will be difficult is what Mr. Bhushan is doing, which is, you know, figuring out those details, the back end plumbing, which is exactly what is the proof of concept required for us to then expand it, whether to the rest of the country, to rest of the population. Do you increase the coverage? Do you move towards OPD? Those are second order problems right now. So it's a great beginning. I'm quite optimistic.
And I think it's fantastic, again, because Dr. Bhushan, you bring in also your background of having worked in countries where we've seen government healthcare schemes which have actually worked. You worked with the IT system of China, which has again been quite a transformation in the way they brought their health insurance schemes out. In fact, the debate, we saw many people on Twitter saying, why are we calling this the world's largest scheme? It's China, which is the world's largest health insurance scheme. But also the lessons from Thailand and other countries. And Amartya Sen and Jean Andres have often pointed out that while India is an emerging superpower, why is it that in health we've lagged behind our neighbors and developing countries like even Bangladesh, Nepal, Sri Lanka and Bhutan? Why has India never been able to tackle that paradox really of on one side being the emerging bright spot of the world and having health indices lower than even Bangladesh?
Well, Ms. Rao actually very nicely pointed out the whole evolution of health sector in last 70 years. One major reason has been that we don't spend enough on health. Right now our spending on health is 1.2% of the GDP, which is one of the lowest in the world, and the lowest among the all emerging nations, and we are committed to increase that to 2.5% in next 7 years, and that will imply that we have to increase the budget by about 17-18% every year, given that we are also expanding by 6 to 8% every year. So that will be a challenge finding those resources, because if we have to give 18% increase to health, something else has to give, and what else has to give, probably that is a major policy debate that we need to have. But without that, if we don't have money, of course we can't provide health services that we should provide.
Are you happy with the allocation you'll have got so far?
We've got an allocation which is enough for a time being.
It's 3,500 crores currently.
Currently it's about 2,000 crores, and we'll get some more, because I think money is not a problem, because it's a scheme that is one of the flagship projects of the country and government of India, and so money should not be, will not be a problem.
No, because the other issue, because UP, Bihar, which Ms. Rao had brought up, and it's true that we saw that enrollments under the RBI MY have actually went down. So in a sense that, you know, that how do you actually bring the states like UP, Bihar, Madhya Pradesh to a level where they actually avail of the scheme in the way it's meant to be, or the fear that then it becomes another Sarkari thing, as Shamika pointed out, we're writing checks from the Finance Ministry in North Block, but when it's getting to the districts of Bihar, what happens with it?
Well, you're right that these three states that you mentioned, Bihar, UP, MP, they account for 1/3 of our beneficiaries. They have more than 3.5 crore families, which is 1/3. And so we actually are paying special attention to these three states. And these states also have learned a lot from their RSBY experience. I was in Bihar day before yesterday, and in Bihar, they are being very careful in terms of what kind of hospitals they take on. In MP, for example, they have tried to restrict the private hospital only to the NABH and not-for-profit hospitals, because they want to start from there so that they can minimize the chances of corruption and fraud. Similarly, in UP, there's a very high level of political commitment, and they are working with the district level officials. And I must say that of course their progress so far has not been as good as other states who've been running schemes, but they're catching up, and I'm very hopeful. Give us one more month, they'll be doing a lot better.
No, it's great that you're actually monitoring it from there rather than from Delhi. But Dr. Paul, if you can come in, the two big C's that critics of the program have pointed out is really the costs and corruption. Because they said that really is something which has been an issue, whether it's been with the private sector, whether it's been with the government sector, that how do we know that these cards are issued and then there's some kind of fixing of the system, there's some kind of rigging, that the best meaning vision of the scheme can fall through if the problem of corruption in the medical system is not addressed. And that's not just with Ayushman Bharat, but the corruption in the medical system is something which is now acquired epidemic proportions.
You are absolutely right, because the way things are, particularly in the context of India, but also in general for a health assurance system of this nature worldwide, there is a huge potential for corruption and leakages. It's a very serious issue. We as a team have tried very hard to make sure that this element is minimized to the extent possible, learning from experiences of other schemes, learning from the best practices in the world, harnessing the technology to pick up those blips which indicate a wrong, let's say, beneficiary or a wrong treatment or a wrong claim. All that has been put together in a very systematic manner. We actually commissioned a very deep study, and based on that, filters have been created.
Like
we will be careful about preventing, and above all, the strategy is to really prevent the right beneficiary, the right admission being made, right treatment, right auditing that goes with the reimbursement claims and so on. Prevention is the key. And then it is detection and then deterrence. So, we are working on all the three elements, and a huge effort is being made. There are audit procedures, there are procedures using IT in terms of identification of the beneficiaries. They will be, as I said, using very high level of IT, including artificial intelligence,
and
to
Aadhaar
pick up the
also,
problems, and Aadhaar by
with
itself.
The Supreme Court judgment.
Yes, indeed.
But you were also disagreeing when Sujata Rao had made that point about primary health care and the focus on that being much more. What would you like to actually come, and then I'll get my
I think what must be understood by all of us is that we come, the budget announcement was about two missions, twin missions. These twin missions constitute Ayushman Bharat, and they should be seen together, as Shamika and Madam Rao said. Primary care is about establishing a comprehensive primary health care system in the country, which is centered around health and wellness centers. Now, these health and wellness centers are the upgraded futuristic vision sub-center for about 5,000 to 6,000 population and corresponding sites in the urban area, as well as the primary health center, which is connecting these 5 or 6 of these in a hub of 30,000 population. Current primary health care is focused rightly on reproductive health, maternal health and child health, and a few communicable diseases, particularly let us say malaria. But that is only 15% of activities. What about diabetes, heart disease, what about detecting cancers, care of the elderly, adolescent health, eye, ENT, this was never part of our agenda in that sense. That 85% is now we have envisioned to be placed along this platform that I am talking about, and this is a comprehensive system. So, expansion of services. We are also adding a new provider, who is a mid-level provider between a doctor and an auxiliary nurse, which is the mid-level provider. Possibly it will be a nurse practitioner practically all over the country, who will take on these extra jobs that were not being done at the sub-center level. Free drugs, free diagnostics, not just those that can be point of care, but also using a hub-spoke model, teleconsultation, follow-up of the patient,
so completely holistic
family health records,
system,
each individual having eventually an electronic identity and working through a national health stack.
Sujata Rao, do you think that's a vision which is workable, implementable and desirable in a sense? Also, that issue is about corruption within the medical system and commercialization, which has also become part and parcel of it. Is I mean, private sector, and I'll get Preetha Reddy in also on that. But there's been a kind of outcry amongst people who can pay for services about the increasing commercialization we are seeing. How does all that fit in with a scheme of this kind? The focus on maybe the diseases which, as I said, which are primary, which you don't have to be admitted to hospital for, but then hospitals start admitting you because of the reason. We know the kind of focus of a medical insurance, the whole over-admission in hospital, which has also become a huge issue.
Yeah. So, in fact, he calls it two pillars. I would say the wellness clinic is the foundation on which this other one has to stand. So, two pillars means two parallel tracks which may not meet. So, I prefer to visualize it like this. So, I think, and the more exciting and really the best policy in a long time has been the strengthening of the wellness clinic, long overdue, needs to be done. And my heart breaks when the lesser attention from policymakers, meaning political class and media from you, is constantly on that insurance program and not giving enough attention to this. This is really the bedrock on which this program will stand on. And so I think the vision that he has said, you see, the government has come up with 12 services that ought to be made available as an entitlement to every citizen, which even covers mental health. It is so important. It is so important that we do that. But it's much easier said than done. And so I would have, I mean, if I could, I would have loved to have seen all the 10,000 crores that they're going to collect from the health cess, all the money that we can spare and have put on this wellness clinic thing, really the next 5 years, because it's not only the refurbishment of the centers to be able to cater to these 12 services, but the human resources required, counselors. It's just not the doctor, counselors, nurses, male workers. There are a whole range of other skills.
Especially in rural areas, the shortage
for
of
elderly
any
people,
medical
for home
professionals.
nursing.
Yes.
So there's a whole range of skills that are required in the human resources, which will take us at least 5 to 6 or 10 years to really see the transformation, which is so important. And they'll also be providing the critical pathways or referral pathways to the hospitalization.
In fact, I want to bring Preetha Reddy because
finally,
yes?
So the question of corruption is so fundamental, and I'm glad you raised it. Till we do something about corruption, it's going to be a very hard ball to make a success of this program. And I'll say in one state, a research study I was heard about was in one state, the insurance, the hospitals were taking the insurance money, but also charging upfront the money from the patient. So they were making it twice. And now that will never be caught in this IT thing. So IT cannot be a substitute for basic integrity and values on which the health sector really stands
and
on.
human checks and balances. But Preetha Reddy, you wanted to come in also on that aspect really of the involvement of the private sector. And while government health services we know often get a bad rap, but the private health sector has also been facing a series of controversies recently on issues of overcharging, of commercialization, etc. How does that fit in then with a government huge health welfare scheme of this kind? How will it be addressed? And also, of course, the point of 5 lakhs a year. But we know that, for instance, if it was cancer surgery or even a heart surgery, 5 lakhs wouldn't be a year, but would probably go in a hospital, in any private sector hospital, in about 4 days. Go ahead, ma'am.
So, Sonia, it will, the cost of a high-end cancer surgery or a robotic surgery is there. And I think we have to come to terms with it. But for most hospital interventions, I think people will manage with the 5 lakhs. I mean, we've done various cost studies. While we understand that, the actual costing the way it is today may not be enough and we might have to do a little bit more. But I think that is just work in progress and dialogue and a dialogue going on. On the corruption front, I think, both private sector and the public sector have been bashed tremendously on corruption in healthcare. And I think we all have to work together and do whatever we can to stop it, number one. The second thing is that technology actually can play a huge and a vital role in corruption. And 2 things can be done, is that if we have standard clinical codified protocols, which again I know is being done now with the government, people will actually know that, what it is that it entails for a certain admission. And that gets coded, and then there is a very upfront pricing mechanism in place for it. So you don't really overcharge. I think that overcharging, that concept really has to go. And it is something which the public and private sector have to work hand in hand. Media has a large role to play. Without saying that, there's just overall corruption everywhere, maybe it's good to spend some time to rationalize and say that, for a certain procedure, for a certain intervention, this is the kind of cost to expect. And I think that would be a great thing. And it might help people be more aware so they don't get caught into this whole corruption game. Right. Also, there's a thing called the NABH, which is a standard, which is a quality certification, which the government is very involved with giving out. I think one of the aspects of NABH is to really go into clinical interventions to find out if there was, an unnecessary intervention or was the outcome really the right thing. And if NABH can actually be empowered even more than what they're doing now, because now they're looking at physical infrastructure and they're looking at certain systems and protocols, which is good. But if this is a big problem, I think they may be the right body.
A major intervention to do.
Yeah, so I think they need to be empowered, and it can be introduced into the NABH certification, which may be the quickest and the lowest hanging fruit to be able to do it. For example, hospitals which are signing in for the Ayushman Bharat scheme should all be NABH certified.
Dr. Ravi, I just wanted to actually come in on that aspect as well. And this is an issue that has been raised earlier when it concerns the fact is that 80% of healthcare provision is currently the private sector.
75.
Is it 7? Yeah. But are we in a sense abdicating responsibility of fixing our government healthcare services? It's all very well to bring in private hospitals and accept what is reality, but in countries around the world, and again I think this has been pointed out by Amartya Sen, Jean Tres and various other public health professionals, the focus has to be on giving your public health, public education as well of a quality that everybody can access it, and the disparities cannot be so high as it currently is.
So first of all, Sonia,
does this ignore that aspect?
I'm going to send you some more recent research. We have to move beyond Sen and Dres, particularly when it comes to human capital, and I do think I should send a box of research material to NDTV in particular.
Well, that includes Srinath Reddy, who heads the Public Health Foundation of India.
Absolutely, and to all of us who have been big promoters. Now, I think it's important to understand the economics of healthcare.
Yes.
It's all very nice to be emotional and want everything, but at the end of the day, there is a budget constraint. We have to figure out the effectiveness, the economics of it. Primary care is a part of the healthcare sector where markets do break down. You are unlikely to find private care providers jumping into primary care because the margins are very small, and though you have massive scale, but you are likely to see them, which means you need the government. So which is why the wellness center is such a critical component, where the government has a mandatory role, because the private sector is not going to come up with solutions for that, number one. Number two, tertiary care, you do have some of the best super specialty hospitals in India. We have medical tourism booming essentially because of the tertiary care, and we must sort of encourage it further. But there's another component to tertiary care, which is training and development, research and development. You're not going to find too many private sector people do it. Again, some of the best institutions in training and research are with the government. And the reason for it is just plain economics. So there is a role for government, there is a role for private sector. It's important to understand that each of them is going to do what is viable for them. So neither the government nor the private sector should abdicate its responsibility, or we should even ask for it, frankly. But this is where we get to the regulation part of it. Private sector in India has blossomed, and of course there is a lot of problem with it as well, but that is really now getting to a stage, let's put together the plumbing, the architecture for regulating the private sector space, which means NABH, as Preetha mentioned, NABH is fundamental for accreditation. Go beyond the checklist of infrastructure and outputs to really looking at quality of care. We are yet to have a serious discussion on what is quality of care, and that means getting to patient level data, saying what is the average length of stay, how many hospital acquired infection, readmission rate. Now we are getting to metrics which are far more evolved, and frankly the discussion in all the OECD countries today, because the nature of healthcare economics is such that it is only going to get more expensive. We can use technology, but in the long term, every country has to shell out more for healthcare.
No, and of course it's an interesting aspect that even the most developed countries in the world, whether it's the US and Obamacare and Great Britain, have struggled with that, but Europe and the Southeast Asian countries have had better success. So just in the terms of the big learnings, Dr. Indu Bhushan, where we talked about your experience as well, what has been the big learning? Shamika makes that point, it's not about either side abdicating, but is there a worry of getting overshadowed?
Overshadowed of what?
Is there a worry of the fact that the government, in a sense, and I think this was the same argument in education as well when RT came in, that the government shifts its responsibility to the private sector for what the government should be providing its citizens for the taxes they pay.
Well, Shamika was making a different point. She was saying that there are few things where government has to provide those. Primary health care, research and development. But for tertiary care, government doesn't need to provide those services. maybe certain kind of services, but private sector can provide that, but government can finance it, especially for those people.
I get that, but I'm just saying that on the issue of whether government is going by the models in Southeast Asian countries, what do you think has been the most viable model or the big learning for India from there?
Well, one of the best models in Southeast Asia comes from Thailand. Thailand actually spends a lot of money. They have 3.5% of their GDP on health, but also they have a very strong public health system, and the linkage between public health and tertiary care is also very strong. So I think we should be looking at that kind of model where we have a very strong base where all the public health care facilities are provided by the government and financed by the government, but tertiary care is shared between government and private sector, and but financed by the government for the poor people, but also co-financed with the, and there's the pooling of all people, so where there is a sharing of risk between healthy and unhealthy, between rich and the poor, and elderly and the
But where is
young.
the focus on strengthening public health care coming from? Because in this system now we're looking at obviously paying for insurance. Where are we looking at the focus on strengthening public health care?
Like what you're talking about, one leg or the bottom of the pyramid
In the
that
wellness
Mr.
clinics.
said, health and wellness center. I think that is where we are providing emphasis by strengthening public health centers, public health care in the.
Well, I'll go to Sujata Rao. Go ahead.
No, I have two responses to your questions that you've asked. One is that NABH, which is trying to be flagged as the measure for quality. You know, you have to understand NABH is very expensive to get that accreditation. And when we say 80% is private care, let's remember only 3 to 4% is corporate sector, which Preetha and all represent. So the rest of them, of which a large chunk are the Jhola fellows who are doing primary care. Primary care is one of the most competitive markets if you look at primary, secondary and tertiary as 3 different markets. So it's very, that's, you know, that's a point that we have to remember. And then in the middle are a large number of nursing homes who provide, and small hospitals which provide very good, reasonably good quality care at reasonably good affordable prices. Robotic surgery is not, you know, in that context I'd like to say that I think Dr. Paul is trying to set up a technical assessment setup in the DHR which ought to really screen whether this robotic, for example, I'm just taking, technology is the most important and cost effective technology for him to pay for. So that kind of technology assessment system will be coming in the future years. So what I'm trying to say is that there are the larger number of his friends are going to be these small nursing homes, and which should not be allowed to be subsumed by this corporate sector, and we have these giant monopolies coming up because they're going to jack up prices. That's one point. The second is why in India's model, you can't look at other models. Why in India's model, what Indu had said, a mixed model in the secondary and tertiary markets is critical, is because I find from my experience and also data that it's because there's aims, there is a certain what do I say, price stabilization by the private sector. Just imagine RML, Safdarjung and AIMS is off. You see how the prices will shoot up in the private sector. This has been shown in Karnataka, it has been shown in Tamil Nadu experience, and it is shown in Telangana where the public sector is so weak that the private sector prices are very, very, very high. So it is in our kind of a mixed economy model which we have been following the last 70 years, I believe that primary care must be with the government. Why? Because primary care is what does the public health function, which is a statutory requirement for a government to intervene in. Infectious diseases.
Yes.
This is not something that the private sector should be allowed to do alone.
TB, which is one of our
Just imagine TB, HIV
do it.
and all that. These have population health implications, and primary care treatment has to be the government's, and the secondary and tertiary, we have a healthy mix of public
in fact,
and
Dr.
private.
Paul will have seen also the brain drain from AIMS, where the AIMS
Not
best
so much,
doctors
Sonia,
are
not
used
so
to.
much.
Not anymore.
You can't.
That's good.
We
no,
want
it
to
is-
bring them back in thousands.
No,
Excellent.
Sonia, I'll tell you the most inspiring model is AIMS. Not so many people have left as they would have. Their commitment to AIMS, building AIMS is
You
really
were there
quite
for 30
remarkable.
years now.
No, it really is, I have to say,
has
worst
not
class in the
left
system.
AIMS,
But
he's just doing
no,
another
he,
hand.
of course not. I'm talking about the other brain drains. But just to bring in that
I
point.
want to come
yes.
in here, Sonia.
Okay.
2 or 3 things. One is on, on the costing. 65% of government spending, which means state and union government put together, would put on primary health care, and this is emanating from the National Health Policy 2017. So let's say we want to stay on course. So the government's commitment, together with the state government, to put money on primary health care where the money must go, the public money first and foremost must go, is now manifested. And by having a comprehensive primary health care vision through the health and wellness center, we have a way to move forward. So we not only have the intent, but we also have the wherewithal on which this money will go: free diagnostic, free treatment, free connectivity, free follow, all those things. So this is first part, and it must be emphasized. The two measures have to be seen together. My second point relates to the impact on the accountability of the two systems, which comes through the PMJAY, the health assurance scheme. When we are impaneling, we are going to ask for a few certain criteria, significant criteria. Tomorrow it can be more complex. Tomorrow it can be entire NABH or whatever. So it brings in a quality element as a strategy without having to pass a law to regulate. We bring in quality. Dr. Bhushan is not impaneling every hospital that puts the application in front of. That's number one.
I've heard he's very tough about that.
Number two, cost. The benchmarking will now be PMJAY for the private sector as well. That's where it will now stabilize. This is a benchmark on which for medical tourism you can have 10 times or 100 times, doesn't matter. But this defines the cost structure of the private sector.
Heart surgery will cost
And we
this
are
much.
mindful of the fact that this costing, this pricing must be fair for sustainability to the private sector. There's nobody's intention to squeeze it. So the cost gets sorted out.
Though Preetha Reddy has raised that 2 or 3 times.
No, it is
about
okay.
The
This is a
dialogue,
moving. We are moving in that direction. We'll find the right numbers. It's a matter of time, and they know that we didn't have data from them. And every private hospital doesn't charge the same way. The cesarean section varies from 20,000 to 150,000. So which one is to be regulated? But let me come to the third one: accountability. Both of the private sector as well as the public sector. We're going to take a feedback how they have given the service to the people. We have data on their outcome. It's a game changer. And on the public sector, what the public sector earns through the PMJAY scheme, that money, which is equal to the same as the private sector, stays with the public sector hospital to be used for strengthening the facilities, facilitation, and even incentivizing the doctor. So even within the sphere of this, there is an effort to strengthen the public sector.
That's a good point.
And public sector investment that you are referring to, please appreciate, I disagree with ma'am to an extent. We cannot wait for one thing to come before the other. If I have a little pocket, money in my pocket, I am going to a private sector anyway. So if the government and the people of India are enabling themselves to do the same thing, harnessing the private sector which is out there, it should be respected and welcomed. We are willing to go together, and this money that we are talking about is very affordable.
Okay, fine. The final round of this dialogue, really, and let me end by saying what I did in the beginning, that I really think this is a game changer in the sense that we put health on the mainstream political agenda, and that really is something which is laudable. But the larger question also is of the politics that comes around it, because as we said, that it's immediately being tagged as Modicare. So like it was tagged as Obamacare, which in a way may have been the kiss of death for it, because then automatically we know other states are a bit worried about being tagged as part of it. Will we get subsumed in it? The Mohalla clinics, for instance, in Delhi is something which is we've seen the World Health Organization, others say that this is a great scheme. Do you think that politics can derail the best possible schemes? Where, in a sense, the government's lucky that you got so many BJP-led states now, so they're all on board. But how do you think this will actually play out?
I think competitive politics is great for India. We've seen the infrastructure in UP under Akhilesh Yadav become exemplary, primarily because he was facing the competition. We are seeing now almost a convergence of the right and the left, where Rahul Gandhi becomes a Shiv Bhakt and RSS is becoming open to it. So I think convergence is great. Competition is excellent for people. And eventually the program is about empowering people with money. They are going to vote with their feet. They will not go to a hospital which doesn't provide good services. But, you know, I think, Sonia, this is an important point which, you know, if you look at the NFHS data, people actually go to public care hospitals when they're there and they function well. In fact, the NFHS4 tells us that in most of the states, 75% of people across quintile groups are going to public care hospitals. In places where it doesn't work, less than 15% across quintile groups. So it's not the case that the rich are seeking commercial corporate hospitals and the poor are going to the public. Not at all. The quality matters and people are voting with their feet, so it sort of empowers. And eventually politics is about empowering people, I think. And in this case, I think good health policy makes for very good politics.
No, and as I said, it's good, it's competitive about health and not about issues that deal with caste and community. I think it's great that it's competitive health. But Dr. Indu Bhushan, final words with you, because you're the man going out there meeting different chief ministers. I know you've just got Punjab on board, which is a Congress state. So that's a good bit of negotiation. In fact, it reminds me of Nandan Nilekani in Aadhaar when he had to go around convincing various chief ministers. Now, Delhi is still left out. And as I said, the Mohalla clinic seems to be a good model to adopt in states across India, or look at it as a larger central government thing as well. How open is your program going to be? How are you convincing the remaining states to actually come on? And again, as somebody who's not a politician, is it feeling good for you to be back? Why did you come back and decide to take this on?
Well, to answer your first question, I think 90% of the population is already covered. We have only 4 states which are left, and Kerala is actually almost in, and we've been having discussion with Kerala. I think they should be signing in next couple of weeks or so. Now, Delhi is actually important state for us, not for Delhi itself only, but also for national portability, because a lot of people from UP, Bihar, migrant workers live here, but many of them come here for tertiary level care. So I think we are very keen to have Delhi on board, and if Delhi doesn't come on board, we'll be finding some solution how we can use the great infrastructure that Delhi has in terms of providing tertiary health care. Now, the second question, that why did I come back? I think it was a no-brainer. It's who would give up a chance of leading such a great scheme which has such a great potential.
Final thoughts on the dialogue side. Preetha Reddy, final thoughts from you. We've heard lots of talks about costs, corruption, etc. But as I said, we should end with the larger vision and the optimism of a game changer.
I know. You know, the education and health is a fundamental right. And for us to segregate it between, you know, private, corporate sector, people who can afford, cannot afford, at the end of the day, the blood which runs in our veins is red. Let's not forget it. I think the government has done a fantastic thing by bringing this program on board. We may find many flaws in the system, but nobody till now had the courage to bring it on board. We must acknowledge it. Some of the states are doing very well, like, you know, Tamil Nadu, if you go to the new government hospital, it's fantastic. We have been sending people to go and see that, to look at the level of outcomes, quality, cleanliness, so on and so forth. So I think the government is capable of doing a phenomenal job. We understand that there is money in the system. We have to just find different methodologies to really use the money wisely so that we provide access to a larger population. Can the private sector and government sector coexist? I think it's a bit of dialogue, it's a bit of rationalization on costs, it's a bit of being aware of corruption and trying to get rid of it, and definitely adoption of technology, because if people can really have cell phones, our penetration is 800 million, why can't quality healthcare be for 800 million? So I think there is a way forward. The answers will evolve as we go along. But the biggest thing which we have to do is to decide to work together. And I'm happy that even that is happening, because today I see a lot of dialogue with private sector, with, you know, the NITI Aayog is really encouraging people to come and discuss, talk, evolve systems.
No, absolutely. And I think everyone around this table, and even in Chennai, would agree that the dialogue, the working together
so I think
to implement
politics aside,
a scheme like this is really what is needed.
Let's
it's only been a month,
politics.
so I hope we have many more dialogues like this. And I hope Dr. Indu Bhushan will be back in 6 months, Dr. Paul, and we can all discuss this, how it's going then. Thank you very much, all of you. Thank you very much for being part of this dialogue.